Okay. Yalla, guys, can we start? Okay, so
Yeah, sure.
yalla, part 2. Okay, as in just to recap really quick, we said last time, and we are focusing on narrow complex tachycardia, in other words, SVT. Okay, if it's, we said, yani, you want to make sure if it's regular, then you think of something reentrant. If it's irregular, then it's either AFib, which is not very commonly seen in pediatrics, of course, but you know, in adults. However, it could also be atrial tachycardia or flutter with variable AV conduction. Okay. In addition, we said you have to hunt for the P waves, and if the P waves are visible, then you have to determine the P to QRS ratio. And if there is more P's than QRS's, then you think of atrial tachycardia or flutter. Okay. If the P QRS ratio is similar, then it could be anything. If the QRS is more than P's and it's narrow complex, then you think of what? You remember, guys, what is the main diagnosis in such scenario? So more
WPW?
No, more QRS's than P's, but narrow complex. It's rare, but if it happens, what do you think of? Remember, AV and RT. Because AV and RT, the circuit is only within the AV node, so it doesn't matter whether V is conducting or not. Make sense, guys? This should be very well understood by everyone. Okay.
Yeah, 100%.
You agree, Wael? Okay. If you don't see P waves, this usually means the RP is super short, such that the P wave is hidden within the QRS. This is typical AV and RT. Okay, guys? And then we also said the RP interval, if it's long, بمعنى more than 50% of the RR interval during tachycardia, such as this example, you think of atrial tachycardia, slowly decremental or slowly conducting accessory pathways, or atypical AV and RT. صح, guys? وقلنا if it's very short, you think of AV and RT. If it's in between, then it could be many things. Okay, it doesn't help you as much. تمام, guys? قلنا focus on the onset and the offset. If there is the V to A always steady and regular and married to each other, or it's dissociated. قلنا the P axis during tachycardia, if it's superior axis, it's less likely to be accessory pathway mediated or AV and RT, and it's going from top to if it's inferior axis, from top to bottom, then it's coming from somewhere up top, then it's not accessory pathway or AV and RT. Remember all these things, guys? Well, you don't remember. I know we talked about so many things, but this is a quick refresher. Okay, any questions for people who attended last time? Everything I said does make sense. Well, you need us to review something.
Clear for me.
Okay, but remember when we said adenosine response, if the AV node is part of the circuit, it will stop with adenosine. Remember when we said if you pace fast, then if it's flutter or SVT, AVRT or AV and RT, it will terminate. If it's atrial tachycardia, it may not terminate. Remember we said shocking the patient usually is when you shock a patient from SVT, the AV NRT, AVRT, flutter, and fib, they are all responsive to shocking, but for example, not focal atrial tachycardia. Remember? So we said all this last time. Okay, please review it because it's so much information. Okay, and we will not review it now because it will take forever. Okay, but interrupt me if this is another slide to refresh your memory. So like we said, if V's equals to A's, then it could be many things. Let me Shah, I will mute you. Okay. If V's more than A's, forget ON VRT and ON FRT, just forget them. If V is more than A's, then you think of AV and RT. Okay. If A is more than V's, you think AV and RT and atrial tachycardia. Okay, guys? Make sense? We said about the VA interval, but
Yeah.
just this is the way I think of it. If it's super, super, super short, meaning less than 70, this is AV and RT. Okay. Okay, guys. Shah, Shah, please mute yourself, Shah. Okay. Okay. If it's long, very long, you know, more than 50% of the RR interval, then you think of these atypical AVNRTs, atrial tachycardias, slowly conducting accessory pathways. Okay. If the atrial activation is from high to low, then it's not coming from the base of the heart. It's not coming from where the accessory pathways or AV node inserts. So it's atrial tachycardia. Okay. We didn't talk about this yet, so we'll just skip this. If the SVT terminates with a P wave, then this is not atrial tachycardia, because if it terminates with a P wave, then the AV node blocked. So why would an atrial tachycardia terminate when the AV node blocks, right? It's not atrial tachycardia. This is very helpful observation. صح, guys? Okay, if it ends with a V, it's not very helpful. Okay. And then we talked about, let's skip this for now, number 5. And then for number 6, we talked about if there is bundle branch block or aberrancy during the tachycardia, and if it was narrow and then became wide, and the tachycardia cycle length changed when it became wide, then you know that there is an accessory pathway that is ipsilateral or at the same ventricle to that of the block. Okay, يعني بمعنى, and I think I went through this last time quickly. Let me just find my pen. بمعنى, imagine this is your circuit. Okay, you're going down the AV node, up a left accessory pathway, and then down the AV node. Okay, if the patient developed left bundle branch block, okay, during the tachycardia, so it will go down the right bundle and then up the left. So the tachycardia would prolong. Okay, guys? Make sense? The VA would prolong. And usually when VA prolongs, if the AH remained the same, the tachycardia would prolong. Okay? Okay. Okay, so now let's go to part 2. Okay?
أنا بس سؤال يا دكتور wanted to ask and I was trying to save it من last time but I'm afraid to forget it. Is there something called V flutters?
Yeah.
And I heard this once and some people were saying it's
so you
so
mean
rare that we don't have to do it.
you mean ventricular flutter, right? يعني
Yeah.
There is, I don't like to use this term, but it just means it's a monomorphic VT that is rapid, like atrial, you know, think of it like atrial flutter. Usually it's very rapid. So, and monomorphic, like, you know, sawtooth appearance of the P wave. Same thing with the, it's like a QRS, very rapid ventricular tachycardia that is monomorphic or regular. Okay. It's just, you know, description of the a specific ventricular tachycardia. Okay.
But it doesn't exist. Yani, this is the thing.
It doesn't what?
But it does exist.
It does exist, but yani, it's usually very fast. People, it's not very well tolerated. You know, it's a malignant type of VT. Okay.
Okay.
Good question. Okay. So now we reviewed the patient's SVT. Now we go into the EP study. Okay. Okay. So at least for me as a pediatric electrophysiologist, usually we use general anesthesia, right? So imagine it's a PVC case, which is, we're not going to talk about it today. You know, I worry that general anesthesia might suppress the PVC. Imagine if it's an AV-NRT case, I worry that general anesthesia might suppress induction of AV-NRT, and hence the end point of the study would be difficult, okay? So I have to think of the anesthesia, how aggressive am I going to be in terms of anesthesia for that specific patient, okay? You know, depending on the SVT type, I have to think or plan ahead, how aggressive am I going to be to pace the patient? For example, if it's a flutter case, you know, like you guys know, I would have to pace the atria very fast, you know. But if it's SVT case, I may not need to, and risk the patient inducing AFib and then shocking the patient, and then maybe ruining the map that we already did. So knowing the previous diagnosis is very helpful. Again, if you don't know whether it's flutter or SVT, you might not be aggressive in pacing, and then you may never induce the clinical tachycardia that the patient had, and then you might miss the case. Okay, so if the patient has complex surgeries, multiple surgeries, entrainment mapping is very important. Okay, so I have to keep this in mind. If it's another complex patient or very small patient, I need to go transeptal, maybe ICE or TEE is helpful. Okay, so if we need ICE, I have to arrange with you guys. If I need TEE, I have to arrange with the echo people. Okay, if it's a complex, arrhythmia substrate like complex atrial tachycardia, I need a high density mapping catheter like Pentaray or Grid. Okay, and I have to figure out whether we have it or not, and so forth. Okay. If it's a long procedure, I have to, maybe just schedule one patient that day. Okay. If, in pediatrics, because they had multiple surgeries, they might have issues with access. Okay. So I have to think, okay, am I going to have enough access for, reference, for ventricular pacing, for whatever, So I have to think of all of this before the procedure so that the procedure outcome would be, the best possible. Okay. I have to think, can I do 4 catheter study, or maybe 3 is more than enough, depending on the size of the patient and so forth. Okay. Again, with specific congenital heart diseases, the AV node might be abnormally located. For example, there is something called atrioventricular septal defect, where the AV node usually is posteriorly displaced. In other words, it's more towards the CS. Okay. And so forth. Okay, and so there are specific patients that they might have 2 AV nodes, like heterotaxia patients, they might have 2 AV nodes. Okay, so these are, and we had seen this, so these are, especially with pediatric patients, you might need to be aware of this before the procedure. Okay, again, if there is an ASD patch closure, you might need, it might be difficult transeptal, you might need radio frequency needle, you might need safe sept, you might need ICE and so forth. And you remember, you guys, during the workshop, you had a difficult transeptal case, remember guys, Wael and Maryam?
Yeah, we
right?
use the RF on the needle.
So this is all, you have to plan ahead. Okay, if say a patient has CS that is atretic or doesn't exist, there are occasionally anomalies within the CS, then you have to have a plan B. Okay, where should my reference catheter be? There is something called esophageal lead, meaning a lead that goes in the esophagus and usually senses the left atrium, and it's usually very stable, that you can do. Okay, or you can place a lead in the pulmonary arteries that that surrounds the atria, and you might sense the atrial signals, in this position, instead of CS, for example. Okay, or you might place it in the high right atrium and so forth. Okay, but obviously you guys hate when that catheter moves, so it has to be in a stable place. Okay, there are other baffles that you might need to cross, Fontan, surgery, I can explain this later, but it's like a tube outside the heart that you need to cross and go into the heart. Okay, and there's something called the Senning procedure, mustard procedure, or atrial switch surgeries. All these, there are baffles within the atria that you might need to cross to target a specific arrhythmia substrate. Okay, anticoagulation, if it's a single ventricle patient, or if you go left-sided, any left transeptal left-sided procedure, you need to anticoagulate. Okay, and then if you are thinking of epicardial ablation, you have to reverse anticoagulation and so forth. You might do epicardial first and then endocardial for that reason. If it's a single ventricle or complex congenital heart disease, or there's prosthetic valves, you might need to give antibiotics pre-procedure. Okay, and if it's a complex anatomy, you might need to do imaging beforehand and then merge it with the 3D system. Okay, so all these things you have to think of before the EP study for the complex patients. Okay, and you have to knowing this, you might also give us, suggestions. And sometimes people are busy and miss things, and you might suggest things. Okay. So now, after thinking of all this, then obviously, you insert your catheters, and God forbid you do X-rays. I don't like doing X-rays, but if you do X-rays, the famous views that you look for is, straight view, straight PA view, LAO, and RAO views. Okay. Just so you guys know, so this is straight X-ray a PA view. And usually your high right atrium catheter is positioned on the left side of the screen, and this is your His catheter. This is your RV catheter. Okay, this guy, and then your CS catheter. Okay, it's clear to everyone, right? Okay. In the LAO view, this is your CS catheter. Okay, and then you can imagine your mitral valve is here. Okay. And then this is your His catheter, and you can imagine your atrial septum, ventricular septum is here. Okay, so that RV will not cross the His in LAO view. Okay, if this is an RAO view, this is your CS again. This is your CS catheter. Okay, and then that CS catheter divides the heart into posterior and anterior. So this catheter that is anterior, is in the RV. Okay. This catheter that's posterior is in the His. Okay, this is how you know which is which. Why is this a His? Why is this the RV? Why is this CS? And so forth. Okay, so when you are mapping left-sided catheters, the best view is LAO. Okay, if you want to position, the His and the RV, you might want to use RAO. Okay, and so forth. Make the imaging, the views do make sense to everyone, guys, because obviously we do use X-rays sometimes, and this is how you should expect. This is where the expected position of each catheter on that specific view. Okay. Questions? Okay. No questions? Okay.
Clear.
Clear. Okay. So, just specifically for the His electrocardiogram, the His EGM is a signal that is seen within the His bundle, not the AV node. Okay, the AV node, you do not see electrical. We do not see the electrical activation within the AV node. We only see the electrical activation at the bundle of His, which is just distal to the AV node. Okay, this is an important piece of information that you need to know. So, for example, this is a cartoon image. Everyone knows that. So this is your CS, right? This is your right atrium, and this is your right ventricle, and this is your His cloud. Okay, guys. Okay, so there is something called triangle of Koch. Okay, so which is margined by the His. Okay, by the tricuspid valve leaflets, and by your CS. Okay, and the AV node is usually at the apex, at the superior apex of this triangle. Okay, so you see the His here. This is the bundle of His. Your AV node is a little bit just inferior to that His cloud. Okay, so say you want to ablate this patient AV node, you should place your ablation catheter somewhere here. Okay, not here. Okay, so this is just so you know, because sometimes when we ablate the AV and when we go high on the AV for slow pathway modification or ablation, when we go above the CS os, which is roughly here, when you go above the CS os, you worry about ablating the AV node. Okay, questions here, guys? Okay, so okay. So this is a nice 3D map as well of a patient with, with the patient with AV-NRT. Anyways, so again, this is your CS, this is your His. Okay, In this case, it's a little bit lower His than what I typically, see or expect. I would expect the His to be somewhere here, but in this case, a little bit lower than usual. And then this is, then like we know, there are fast and slow pathways inputs into the His. Okay, so this is your fast pathway, which is, more up top here, and this is your slow pathways are here. Okay, guys. So this is why we target this area. The slow pathway is more posteriorly located. Okay, guys. And usually where the fast and slow pathway collide, this is where you very often get your accelerated junctional rhythm. Okay, the collision site. Okay. Anyways, but the point is that you target the posterior. You target the slow pathway, which is posterior to the His, obviously, and you try to go as low as possible, and you target that signal that is called often, typically called hump and spike signal. There's a hump and there's a spike. Okay. This is one of our patients, 14 years old, that we did, at our hospital, and this is the signal at this location, and there was immediate junctional acceleration. And this is it's a very nice signal that you look for. Some people call it fractionated AA, but typically it's described there is a hump, meaning not very sharp signal, and then there's a not very sharp signal component and a sharp signal component. Okay, this is what you need to look for, and generally a smallish signal compared to the V. Okay, and obviously below the His, and so forth. Okay, so this is where we target our lesions. Okay, and then in this is another patient that again, this is your His. Okay, the AV node is somewhere here, right, guys? And this is your slow pathway. Okay, guys? Questions? Okay. So
very clear.
Okay, so now our catheters are in position. Okay, we often skip this step, but we should try to make it a routine. Okay. Okay, we should try to make it a routine of measuring the basic intervals. بمعنى, you have your A, you have your H, you have your V in the His bundle catheter. Okay, so you measure AH, you measure HV. Okay, and then you can measure from the earliest atrial activation to your A in the His. This is, so you're measuring from A here and your earliest A. So this is a time. This is the time it takes for the atria to depolarize from the sinus node to the His. Okay, it's called intra-atrial conduction time. Okay, so these are your basic intervals. So the PR interval includes your intra-atrial conduction time, includes your AH interval, includes your AHV interval. Okay, and your QRS interval you measure from the onset of the QRS to the termination of the QRS. Okay, and then of course the sinus rate, or the cycle length, basic cycle length rate, is from A to A interval. Makes sense, guys? Okay, but this has to be routine and quick.
Yeah.
It has to be done quickly. It takes 5 minutes to measure these. This is if it's a routine and you do it quickly, then it will obviously will not take so much time. Okay, and then this is our typical signals that we see. Again, this is your A, this is your H. So you measure from the A to H. You should measure from the earliest atrial activation, from the activation to the A in the His. This is your intra-atrial conduction time, and then from the A at the His to the H at the His, this is your AH time, and then from the H at the His to the V at the His, this is your HV. To the V that is earliest V in the surface QRS. This is your HV time. Okay, makes sense, guys? So A to H and H to V. This is how you measure it. Okay, and then obviously there are normal values. So AH again measures the conduction across the AV node. This is why you have to measure the A at the His and the H at the His, obviously. Okay, and if you have prolongation of the AH interval, this means there is AV node disease. Makes sense, obviously. صح? The HV time, you measure it from the H at the His to the V at the surface QRS, because surface QRS V usually is the earliest V, and and this is the usual value. And then if it's prolonged, then there is distal conduction system disease, beyond the His. Okay, yani there is prolongation of electrical activation after the His. Okay, this is usually seen in adults. Okay, and ischemic patients. Okay, obviously if it's short, then you think of WW. صح? صح, guys? Please stop me if you're not getting this. Okay. Okay, Maryam, تمام. Maryam, Muhammad, Khalid, كلكم تمام? Okay.
Yes, doctor.
Yes, doctor.
Yes, yes.
Okay. Insane. Let's keep going. Okay, so now you measure your basic intervals. طبعا you can measure them in your Carto or in your Insight or at the recording system as well. You can do it, everyone should do it in whatever position is he or she in. Okay. So typically we start with ventricular pacing. Okay. Why is this? Because if you start with atrial pacing, obviously with atrial pacing, you might induce AFib, and and if it doesn't terminate, you have to shock, and it's just a little bit annoying. So usually people prefer ventricular pacing for that reason. Plus, when you ventricular pace, you will have an idea whether there is an accessory pathway or not relatively quickly, and then you just the flow of the case would be easier. Okay, you can do it whatever way you like, is fine, but most people will start with ventricular pacing, and this is also the case in our chest disease hospital. Okay, and then usually we do extra stimulus pacing. بمعنى we do 600 basic rate, something that is a little bit faster than the patient basic rate, which is usually 600 for adults, and for pediatrics maybe 500. And then the second S2 is 400 or 350. Okay, so we do extra stimulus pacing, but some people do burst pacing or ramp pacing as well, but these are less frequently done. Okay, so let's focus on extra stimulus pacing. We pace with extra stimulus pacing, and then we have to observe, obviously. So what should you look for during ventricular pacing? You want to obviously note your VA conduction. Okay, so if there is usually a specific atrial activation pattern, and during the drive and your extra stimulus, that pattern is typically the same. However, if it changed, then you have to take note of this. Okay, and then this change usually means something. Okay, so طبعا usually there is VA decrementation, or the VA time slows down, and if there is an accessory pathway at some point, because usually when you're pacing, and I will explain this in details in a little bit, but just really quick here. So when you're pacing the VE, okay, and there are two ways to the atria, back through the AV node and back across an accessory pathway. Okay, usually initially the atrial activation is starting from both these sites, because they're both active or conducting. At some point the AV node might decrement, and then you get more atrial activation eccentrically across the accessory pathway. And so you will see initially maybe looks normalish, and then suddenly it doesn't look normal. Then then because of the AV node decrementing or the AV node slowing conduction, you have more enhanced conduction across the abnormal accessory pathway, and then the diagnosis is more obvious. Okay, sometimes you see A and then H. Usually when you V-pace, you don't see the His signal because it's buried within the QRS. But sometimes with the look at this. So you V-pace, guys. Okay, you go up the Purkinje system, up the His bundle, and then up the AV node. صح? Okay. Sometimes when you go up this delay is exaggerated such that you see the His somewhere here. So you might see it retrograde His, but usually it's buried within the QRS stimulus and the QRS width. Okay, so you don't see it. But if you do see it and you see the A before the His, then the atria was activated through an accessory pathway. صح? Makes sense. يعني if there is no accessory pathway, the hiss has to be before the A. عادل guys?
Yeah.
Yes.
Yeah,
yeah.
makes sense. Yeah.
If you're going up the AV node, you will see V, H, A. صح? If at some point you see V, A, H, then you know A activated because of an extra nodal pathway. صح? Somewhere before the AV node, hence then there is an accessory pathway or additional connection between the V and the A.
It went up to the accessory pathway.
Yeah,
right.
But this is rarely seen. ليش؟ لأن you don't usually see his retrograde. Okay. Sometimes you see it. If you see it, it will be nice. Okay. Anyways, typically you see decremental conduction if there is no accessory pathway until it blocks. Okay. If you burst pace, which sometimes we do, you usually see 1-to-1 VA conduction. Okay. Let me just mute Hisham. If you burst pace, you would see 1-to-1 VA conduction. And then, بعدين you might see one kickback. Okay, if there's no accessory pathway, بعدين it blocks. طبعا if there's an accessory pathway, you might not see one kickback because the accessory pathway doesn't one kickback, doesn't gradually prolong. Okay, and I will show examples in a little bit. Okay, but this is briefly when you V pace, extrastimulus V pacing. This is what you should know. Your atrial activation, is it changing? Is there A prior to his? Is there decrement or not? Is there one kickback or not? And then if you induce as arrhythmia, how was it induced? Okay, guys, these are your questions. These are the questions that you have to keep in mind, and accordingly, review the tracings. Okay, or know what is the potential diagnosis. Okay, okay. So now let's just speak in more details. So now this is an example. Okay, I need your cooperation here. So now we are this is your S1, this is your S2. Okay, so your V pacing, obviously. You see the V is nicely labeled and your A is nicely labeled. Okay, is this retrograde atrial activation normal to you or not normal to you? This is your first question. Anyone can speak up.
And I want to give space for others, but
don't.
Seeing this,
okay.
This looks normal because the hiss is coming first. Hiss on A is coming first.
Hello.
The A on hiss.
صح. Excellent. So you are V pacing here. You will see earliest A at the hiss distal. Okay. Okay. Hello. This is your earliest, or maybe his proximal. It's difficult to tell, but they are roughly on time. Definitely before your CSs, and your CS is from proximal to distal. صح? Well, your high right atrium A is late. Okay. But that's, in other words, that's normal / concentric atrial activation. Okay. Hello. You heard of the term concentric. صح? Some people use concentric, some people use normal, whatever. Okay. And this patient, the next S2, or subsequent S2s, eventually you will see gradual prolongation in your V to A interval and your stem to A interval. Okay, but atrial activation remains the same. صح? It's the same. عدل. It remained concentric except it's decremental. Okay, it's slowly conducting. Okay, decremental just means that with shorter cycle length or pacing intervals, there is further slowing in conduction. Okay, this is a typical behavior of retrograde AV node activation. صح? And then you shorten your coupler interval further, you will get VA block. صح? Okay, guys. طبعا usually before VA you get you get gradual decrementation وبعدين eventually VA block وبعدين طبعا بعدين what is this? What's happening here? Anyone? What are we observing here? This is the same patient in serious.
This is block.
Yeah, ventricular ER. Okay, it did not capture the ventricle. Okay, فيسمونها هذا ventricular ERP. Okay, okay. sorry.
هي captured ولا not
لا,
captured?
no, did not
refractory ولا
capture.
block?
لا,
I think
refractory.
there is
إيه, ventricular tissue refractory
refractory.
يعني it did not capture. ما في V's, ما عندك best pacing spikes, okay? ما في V signal.
I thought
هذه
that the one on ECG looks
هذه VA
like
block, okay? هذه VA block.
yeah.
This is ventricular ERP, okay? Usually you see this, يعني you see latency, يعني stem to V gets low later and later and later, and eventually there is no ventricular capture, okay? For these terms you need to know, يعني retrograde VA block or ventricular ERP. هذا كله you have to take note and you write them down, especially those not on the cart or inside, those Muhammad, Amal, and يعني صافي, Saleh, and يعني you have to take note of these, okay? Then it would be nice if you include such information in our charts, okay? For future references يعني, okay? فطبعا sometimes you see jump يعني sudden يعني VA decrement بعدين jump, هاي يسمونه retrograde VA jump, okay? And so forth, okay? Okay, and this is another example. You are V pace, ML if you want to take this one. So this is your V pacing. Let me orient you. S1, V paced is your V signals, your A signals, and then S2, V, and then this is your A signal. So what do you observe, ML? And this is your sinus subsequent beat, A, H, V, okay? What do you note here? ML معي؟
ايه قاعدة اشوف ال
Take your time, yeah. If you need help, it's okay يعني. But it's not very difficult. فيعني just look at it carefully.
يعني ان
يعني you are V pacing
بعد
صح? You have to ask yourself how is is there atrial activation? السؤال الإجابة yes صح؟ عدل؟
yes there is
there is. Next question would be, is it normal or abnormal atrial activation? شنو يعني is it normal or abnormal atrial activation? هذا HIS, هذا proximal CS, هذا distal CS. Is this normal pattern or abnormal pattern?
normal
لأنه صح excellent لأنه it's earlier بالHIS or earlier proximal to distal or late for HRA. حلو. Now, excellent. Now there is with this S2, is there atrial activation? Yes or no?
yes there is.
Yes. Is it different than this? Yes or no? في change صح؟
yes في change الشويات later الهس العيب الهس.
أيوة الحين where is the earliest A?
Earliest A is in distal CS.
Well, excellent. So is this retrograde across the AV node or retrograde across يعني extranodal accessory pathway? يعني are we going up the atria through an AV node or through somewhere else?
Through somewhere else because we are
which is يعني accessory pathway.
بعيد عن
accessory pathway located where, in the left atrium or right atrium? Left atrium. حلو, excellent. Okay?
Yes.
Okay?
Yeah.
Okay. زين. طبعا then we go transeptal and then we map that يعني that location. Okay? Okay. يعني again when you V-pace you want to see is there atrial activation يعني 1-to-1 يعني is there retrograde conduction? If yes, how does it look like? Okay? طبعا concentric, like we said, it's when you see earliest A usually بالHIS وبعدين proximal CS وبعدين distal CS وبعدين وليت بالRA. Okay? زين. However, طبعا this يعني finding may or may not be normal. Okay? Usually it's normal, but أحيانا it's abnormal. ليش؟ لأن you might have accessory pathways at the HIS صح؟ Accessory pathways at the septum صح؟ you might see similar atrial activation to normal صح؟ Makes sense, guys? فلذلك when you see concentric atrial activation, it may or may not be normal. يعني مو for sure normal. Okay? إنزين. Occasionally, normal individuals, they might have retrograde A that exits closer to the CS os rather than the his. يعني أحيانا retrograde activation normally for specific people at the CS os, not at the his. Okay. Okay. إنزين. وأحيانا, like sometimes we have difficulty engaging or intubating the CS all the way يعني deep. Okay, يعني أحيانا we only have proximal CS cannulation. Okay, يعني only the tip of the CS or يعني mid of this middle, يعني only midway of the CS catheter is in the CS. صح? But we don't have a catheter that's very distal. So imagine in this case, and you have a left lateral accessory pathway, you might not see it. You might still see earliest atrial activation يعني in your at the proximal CS site, which might be normal in some people, and you might miss left lateral accessory pathway. Okay, so you have to be aware of these limitations. Yani you have to always try your best to have your CS cannulation or intubation deep. Okay, to avoid hell mistake or to avoid hell confusion. Okay. Okay. طبعا, like in this example, this is a very deeply located CS. Okay. 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 If you see, however, eccentric atrial activation, or abnormal looking atrial activation, this is then always abnormal. Okay. إنزين. طبعا, you have to be mindful. For example, go back to this X-ray. أحيانا we can intubate the CS very deep, such that the CS catheter turns go back anterior. Okay. فأحيانا, if this is the case, especially with people with big CSs, you might see early signal in your tip of the CS catheter just because you are very anterior. You went all the way very deep. Okay. So this might be, you might think, oh, there's left lateral accessory pathway, but it's not the case. Okay. فيعني أحيانا you have to be mindful of how your CS is positioned. Okay. So you might see an eccentric activation, but it might not be truly abnormal for that patient. Okay. إنزين. طبعا إحنا because me and some other people, of course, we don't routinely use 4-catheter study. فإحنا we don't routinely have a catheter in your right atrium, up right atrium. Okay, superior right atrium. And if you imagine you have a right lateral accessory pathway, you might, and you V-pace, you might see the earliest atrial activation at the CS his or CS os, لأن ما عندك anything right lateral, صح? You have to be mindful of this in you have to always, if you see normalish atrial activation, it might be normal in a patient, in someone without a right lateral mapping, right lateral mapping. Make sense, guys? هذه كلها شغلات with you have to be aware of difficult cases. If something doesn't make sense, these are things that you need to think of. Okay. Okay. This is why when we V-pace, we always usually we V-pace with shorter cycle length, and we try to document decremental atrial activation, because when you see decremental atrial activation, this is a sign that you are going up an AV node. Okay, لأن usually this is the normal physiology of the AV node. However, pathways usually they conduct until they block. ما في this decremental properties. Okay, طبعا except very rarely. Okay, we will not confuse you with very rare situations. Normally, if you see decremental retrograde A, this usually means you're going up an AV node. Okay, guys? لذلك احنا when we see central plus decremental, we feel more comfortable. If you see central retrograde atrial activation without decrement, I feel less comfortable that we might be missing a septal accessory pathway or right lateral accessory pathway or so forth. Okay. لذلك sometimes I try to give adenosine when we V-pace, And again, if you give adenosine, you should not conduct backwards from V to A across the AV node because there's adenosine on board, okay? If you see VA communication or conduction and with a good dose of adenosine, then you have to always think, is there an accessory pathway that is conducting from V to A and is resistant normally to adenosine, okay? Make sense, these guys? These are very important points, guys, okay? Sometimes we give verapamil or beta blockers to block the AV node to enhance conduction up an accessory pathway so that we better map that accessory pathway. So these are all tricks or things that we have to keep in mind to best map or identify the SVT mechanism for that specific patient, okay? Questions? Maryam, Emil, Khalid, it makes sense, guys?
Yeah, it's clear for me.
Very clear to me, though.
Okay. فاحنا طبعا in pediatrics especially I usually like to do adenosine. We sometimes use these meds, but in adults they are less likely you do these tricks. But once in a while, when it's a difficult case, it's nice to have know these tricks so that you clarify the diagnosis. Okay. Now, like we said, you have to realize as well, further caveats. You have to realize that if you wanna manifest an eccentric activation, it depends on the pacing cycle length. بمعنى if there is, again, you're pacing from the right side, right? Typically we're pacing from the RV. Hello? Typically we're pacing here, صح? And imagine your accessory pathway is very left lateral, okay? And it's in a healthy young individual. Your AV node usually conducts rapidly upwards, okay? In most young healthy individuals, such that it masks, by the atria is activated rapidly across the AV node, and then by the time the left lateral is conducting, your atria is mostly depolarized anyway, so you will not see evidence of that eccentric activation, okay? So sometimes you have to pace fast so that you slow the AV node so that this guy manifests, okay? And in pediatrics, this might be tricky because your AV node is very healthy. In adults, less tricky, okay? And sometimes you have to pace the LV to manifest and left lateral accessory pathway. And when you went transeptal anyway, you might go, across the mitral valve, you V-pace to clarify the eccentric atrial activation. Okay, guys? Sometimes some people do this, okay? So you have to pace adjacent to your accessory pathway to manifest it best. This is why I usually like to map an SVT during SVT. Then during SVT, you are going down the AV node, okay, up the pathway purely, and you're going down, up. When you map as such, there is no competition between AV node and retrograde activation. Your atrial activation is purely from the accessory pathway, and then your map would be best, okay? طبعا assuming you are moving your catheters right, or you're having so many points and so forth, okay? But some people don't like doing this because during SVT, some people might not be very stable. They might be a little bit hypertensive. Plus, when you map and then you want to ablate, the SVT terminates and then the catheter moves. And then if the catheter moved so much, you might lose, the position of the ablation. Usually, but with 3D maps, usually, we mark the site and we can easily go back to that site. But still, people worry about this, such issues. Okay, but in general, I like to map during SVT if possible. Okay. Okay, so very often you will get retrograde atrial fusion, meaning you're going up the AV node and up an accessory pathway, and hence your map would not be perfect. And you're mapping two different pathways, and your atrial activation would be in between. And your best point would be a little bit in between these two sites. Okay, if will not be very perfect. Okay, for example, this is a patient who they are V-pacing here, and you see earliest A roughly in يعني you guys يعني you guys agree earliest A maybe in 7-8 صح in this case عادل guys everyone agrees
Yes, it is in
okay
7-8.
زين ف you know it's not
Yes, doctor.
yeah you know it's not normal صح فيعني you're thinking now especially if the CS catheter is deep in the CS you think now it's left-sided accessory pathway and then you apply S2 okay and then you see clearly atrial activation now earliest at 3-4 you know what happened so what happened here why did the atrial activation change suddenly with S2 anyone خالد ما تكلمت اليوم ولا انت بيزي خالد زين anyone مريم so why don't worry it's easy why anyone
This one didn't capture. I'm sorry, listen, I was getting some food.
okay so no so this is your S2 this is your pacing spike and there is a QRS صح fit captured
Yeah.
عدل
Yeah, I captured. Okay.
and then you see A that is 3-4 earliest at 3-4 versus here A is earliest at 7-8 صح there is discrepancy the question is why
Maybe okay. واحدة منهم ممكن captured على يعني وصلت على accessory pathway or something.
Yeah, يعني انت you are V pacing here, okay? We know this is a left pathway somewhere here, okay? And then, like we said, if you're RV pacing, you will go up the AV node and up the accessory pathway, صح؟ عدل?
Yeah.
Okay. For your earliest atrial activation would be somewhere in between, okay? Now
Yeah.
you gave an earlier premature. Your AV node decrements or even blocked, such that now you have pure left atrial activation. And now this is the site of your, your map would be much more accurate because now you're not having competition from the AV node, you're not fusing, you're not having retrograde atrial fusion, you're having pure retrograde from the accessory pathway. And this is how you should map the patients. You want as much as least least amount of fusion possible, hence during SVT or during short coupling PVCs, okay, such that your AV node either blocks or very slowly conducting retrograde. Okay, guys, this makes sense to everyone. If it doesn't, I will repeat. But this is very critical, very. We do this every day almost, so we have to understand this. Okay Mariam, and I don't know whether Mariam left us or not, but okay I'll move forward. Okay زين okay furthermore طبعا if you it's a nice observation, you see his right. Okay, this is your his catheter, okay, and then you don't see his here, okay, you see VA, but you don't really see his, and then suddenly you see V something A, صح? Has something typically is your his, okay, and that A, sorry, is slightly before the his, so you know that the atrial activation the atria must have been activated elsewhere, not from the AV node, because it's activated, the atria got activated before the AV node even got activated. Make sense, guys? Anna, did I lose you guys? أمل
تمام.
تمام. اوكي وائل تمام. وائل هشام مريم تمام. اوكي people are shy. اوكي الحين okay, so back to ventricular extrastimulus pacing. Sometimes we do see VA dissociation بمعنى you are not conducting retrograde and activating the AA. So if this was the case, usually there is this patient SVT must be either atrial or maybe AVNRT, but this is also rare. Usually atrial. This favors atrial. لأن يعني if you don't have retrograde atrial activation, then يعني there is usually يعني for AVRT you're going down the AV node up an accessory pathway, and when you V-pace you should see that evidence of an accessory pathway, and you don't see it here. If you are يعني AVRT is usually out of the question. Okay, atrial طبعا doesn't matter what's your retrograde atrial activation, it doesn't care. Okay, sometimes we give isoproterenol to confirm that there is truly VA dissociation, especially if the patient is sedated. Okay, again, now imagine you are V-pacing and you are seeing concentric atrial activation. Okay, and then you come down slowly on your S2, and then eventually you will probably see VA block. Okay, block. In the VA, there is V block, like we showed an example previously. And if that block is preceded by decremental slowing, then it's the AV node blocked. Okay. Sometimes you see decremental slowing and then suddenly jumping. So you're going up the initially fast and then slow retrograde. Okay. So typically, if there's no accessory pathway, you slowly decrement and then you block. Sometimes you jump to slow and then you block. Sometimes you don't do that. Okay. If, however, there's an accessory pathway, then you typically don't decrement. You VA conduct, and you suddenly block. Okay. Or if you see VA blocking before prior decrementation, sometimes you block at the Purkinje system distally, okay, which is which might be a sign of Purkinje disease. Okay, but typically in young individual you either see decrementation then block, or no decrementation suddenly block. This suggests accessory pathway. Okay guys, and then like we said before, if you are pacing from the RV and there is left lateral accessory pathway, you might see concealed atrial activation or funny retrograde atrial activation. And then when you pace at shorter coupling intervals, then you see the clear eccentric atrial activation from the AV node being decremental. Okay. However, if you see eccentric right up front, then like we said, there's something abnormal. And then usually if you keep pacing with shorter coupling interval, you might block. If you block at the accessory pathway before the AV node, you will go from eccentric to concentric. If you block at the AV node before the accessory pathway, you will see eccentric into more eccentric because of that. Okay, you might see, depending on which one blocks first. Usually the AV node blocks before the accessory pathway. Okay guys, this makes sense, guys? Please speak up. I just want to make sure I'm not losing you guys. Hisham sakit. Khalid, Maryam, Muhammad Shah, it's all confused. Good. Amal, you're the only one who's speaking. Amal, makes sense?
makes sense. Yes.
Yes, doctor. Yes, I mean.
Okay. زين. Okay. Now this is a little bit difficult. So let me guide you through this. So this is a patient. This is a patient of ours who had tachycardia, obviously. And then this is, just look at this here. Okay, you see, tachycardia, and then this is your ablation catheter, and then you see, and these are the CSs, and obviously the Vs. Okay. So the CS activation is proximal to distal. صح؟ يعني 9, 10, 7, 8 to distal. Okay, and I don't remember how was the CS catheter positioned. Actually, sorry, not proximal distal. The earliest A is 5, 6. صح? You agree, guys? This is the earliest A. صح? For roughly 5, 6 is earliest. بعدين 7, 8.
Almost,
بعدين 3, 4. صح؟ يعني it's very subtle.
7, 8 كمان أعتقد.
Yeah, 7, 8, 5, 6 شيء كذي يعني. It's a little bit subtle. So it's not really concentric. Okay, so that's a hint طبعا. إنزين. Anyways, so that's a hint, and there's something left coming from the left side. Okay, so if yani, obviously your differential would be left side accessory pathway or atrial on the left side. Okay, so like we said, when you V-pace during yani, when you V-pace and you see VA dissociation, then you immediately know that the tachycardia is not AVRT. If you see VA dissociation during tachycardia, if you V-pace and you see you dissociate the V's from the A's, and the tachycardia keeps going. So this is what was happening here. So we V-paced we V-pace at 300 milliseconds, and the tachycardia cycle length remained the same. You see around 323, 24 milliseconds. Okay. So this is an evidence of, this supports atrial tachycardia because there's no VA conduction, and the tachycardia keeps going. Okay, it's a little bit complex, but I just wanted to show you an example of VA dissociation. Okay, but again, you are V-pacing at 300, so you would expect the A, if you are going 1-to-1, you will expect the A to A would be around 300. صح? In this case, it's remained around 320. And then when you stop pacing, it remained around 320. Okay, so that's an example of VA dissociation. Hence, it's not AVRT; it's more atrial tachycardia. Okay, and this is the patient who had left atrial tachycardia, and then you see the CS activation in the cartos nicer. You definitely eccentric atrial activation. Okay. Anyways, so now let's talk about atrial pacing. Okay, so again, we do extrastimulus pacing typically, similar to the ventricular pacing. Okay, and then in this case, you note your AV conduction. Is there gradual AH prolongation? Normally, you'll get gradual AH prolongation, similar to gradual VA prolongation in the AV node. Retrograde and antegrade, you see gradual AH prolongation normally, yani. And the AH prolonged without a change in QRS, this is normal. Okay. And then, if you have an accessory pathway, you will see AH prolonging with widening of the QRS and more delta appearance. صح? Adil guys, yani you're going slowly across the AV node, you're going more across the accessory pathway. So your AH would prolong because your accessory pathway is your AV node conduction is slowing, but your HV would shorten because your V is coming, your H is going further away and your V coming closer. Do you see my face? صح? You see my face or you don't see my face?
Yeah, we see.
Okay. Yeah. Okay, guys. So this is 101 EP. Yani AH prolongs widening of QRS. This is an evidence of accessory pathway with HV shortening. Okay, ML. Okay. Yes. Okay. Hello. And then you remember we talked about Mahaim accessory pathways last lecture, and we said there are special rare accessory pathways that are antegrade only, yani going from A to V, and they are slowly conducting accessory pathway. They behave like another AV node. Okay, And when you have such a case, you A-pace, and then you will see enhancement of the WW, but not similar to your typical WW, where you see immediate enhancement of WW. And with Mahims, you have to pace very fast in order to see the widening of the QRS and delta wave, okay? And I'll show you an example in a second, okay? Okay, sometimes when you pace faster, you develop aberrant conduction. Yani your AH prolongs, but your HV also prolongs. When your HV prolongs, this means you're aberrantly conducting down the his Purkinje system, and you'll get a right bundle or left bundle, okay? This is how you tell, if you see widening of the QRS, you ask yourself, is it WW or is it aberrancy? You see the HV short, WW with delta appearance. HV prolonged with typical right bundle morphology or left bundle morphology. This is aberrant conduction. Okay, guys? Okay. Question? Obviously, you might observe dual AV node physiology or sudden jump in the AH interval, and sometimes, or you might see gradual AH prolongation and then AV node blocking, AV node ERP, and you might induce SVT at some point. And then when you A-pace or when you see sinus rhythm, you always want to take note of your V and where is the earliest V. If you see V that's very early somewhere, then this might be a hint that there is an accessory communication or abnormal communication at that site. Okay, questions, guys? No? Okay. Okay, and since Walu, Amal, you're the only people who are speaking, I will focus on you guys, okay? Sorry about this. Okay, A pacing, صح? A H V, okay? A pacing, صار بالA H interval.
Slow pathway.
Mariam.
Jump.
I'm not giving you numbers, so you cannot tell jump for sure, but there's clear AH prolongation, صح? Okay, and yeah, and there is no the QRS looks the same, صح? QRS, this QRS is the same. There is no hint, there is no evidence of accessory pathway, at least so far. And you have to measure the HV, and you will see the HV. Usually the HV doesn't, in healthy his Purkinje system, the HV doesn't change. Okay, if it shortens, like we said, there's an accessory pathway. If it's prolonged, there's his Purkinje disease or aberrant conduction. But usually for most people, it remains the same. Okay, so in this case, there is AH decrementation. And jump, when you jump, definition of jump is there is more than 50 millisecond prolongation with 10 millisecond decrease in your S1, S2, or A1, A2 interval. You're coming down by 10 milliseconds, and then you see jumping or decrementation by 50 milliseconds. How the definition of jump? Usually we go down by 20 milliseconds, like usually we're not following, we're not, when we say AV jump, we're not strictly, to be very strict about that definition or that terminology. This is your definition. You have to come down by 10, and you will see increase by 50. Okay, but that's an example. I'm not showing you the previous beats because I do not want to take forever. That's your A, that's your his, that's your V. You're pacing the A. Okay, A H V, and then you paste A, and then you see definite prolongation of the AH interval. HV remains the same, QRS remains the same, and then you get a tachycardia that is short RP or long RP tachycardia. Sean?
I want to say long.
Why do you want to say long? So this is your V, صح? Okay.
Yes.
Where is your A's? These are your A's, صح? Okay.
Yes.
زين. your V, هذا your V وهذا your A. They are almost.
Okay, it's very short.
Yeah, it's very short.
Short.
Okay. Hello. Very short. Okay. طبعا, like we said, long has to be very long. In order for long to be meaningful, we're saying it's usually when I say long RP tachycardia, I usually mean that it's 50% beyond the RR interval, and somewhere here. Okay, your A's. Okay, but that's a tachycardia that started with the atrial pacing. You know, I'll tell you that this was a jump and a very short VA interval, less than 70 milliseconds. That's typical AVNRT. The earliest A is in your hiss. Okay, guys. But that's typical AVNRT until proven otherwise. يعني. Okay, صح? This is what we see every day almost يعني, in our labs. صح? Okay. يعني proximal atrial activation, proximal to distal. طبعا ال CS catheter هنا يعني is probably your CS910 لأن هذا pediatric patient. CS910 is probably a little bit in the atria. This is why it looks a little bit latish. Okay, لأن smallish CS, but clearly his A is early يعني. Okay, his A is early يعني. Okay. Well, very short VA. If it's very against accessory pathway. Okay. And plus the onset is with an AH prolongation, okay, or jumping in this case, okay. Now we're coming down S2s, and then eventually you will see what do we see here? What is this? What is block where?
No, wait, sorry. V?
Block, yeah, and you're capturing the A, but you blocked at the V, صح? Do you see his? Well, you don't see his. And you know that you should see his nicely, but here you don't see his. So the block is above the his or below the his?
We're pacing A, so above.
Above, which is normal, and this is normal physiology when you block above the his. Okay, but if you block below the his, that is usually signifies disease, his Purkinje system, which is not normal. Okay, when you block above the his, that's a benign finding. Okay, or more benign finding, and depending on the rate and so forth. But yeah, this is a suggestion of a benign block. Okay. So yeah, like we said, you're coming down the coupling intervals. You might induce SVT, or you might block, and you might see this is AV node ERP in this case. Okay, and so forth. And I showed you what to expect when you're atrial pacing. Okay. So that's a difficult one. This is a little bit hazy. This is one of our patients that we did last year. So I'll guide you through it. So tachycardia, okay, and we're pacing the atria. You see, this is the atrial. We're pacing something, and we're pacing the atria. Okay, so you are A pacing. This is your A. Okay, this is your A. Hello. This is your H, and this is your V. Okay, hello. Okay, so A, H, V. Hello. A. Sorry, when I said tachycardia, I meant we are pacing at this specific rate. And patient is not in tachycardia. We're just pacing fast. Okay, so A, H, V. A.
prolong it شوية تقريبا.
أيوة عليك نور. ال AH prolonging, this is expected, صح? This is normal. You're pacing fast.
So,
you're coming down on your atrial pacing. صح? That's normal. However, A, H, V, and then now look at this. A, you see maybe V before the H. صح? The H is hidden now within the V. صح? Plus, you see widening of the QRS. Okay? But like we said, there is AH prolongation and HV shortening. Okay? That's a sign of what?
هو هنا في حاجتين، يا إما I have induced the tachycardia or I have captured V while pacing, but I'm pacing atrium.
No, we're pacing the atrium. Okay?
Yeah.
Your AH is prolonging normally, but your HV is shortening with widening of the QRS. So that's a sign of accessory pathway. صح?
Yeah. I think we induced the tachycardia here, right?
Well, we are still pacing. We did not, this is pacing, during pacing. We are pacing, we were 250, we were pacing 250. We don't know whether induced, you have to stop pacing and see what happens, okay? But now, and I'll tell you, if you stop pacing, the patient will go back to his usual sinus rate. We did not induce anything, okay? So we are just pacing fast such that we are manifesting WBW, okay? Makes sense, Juan?
I'm actually also, I just wanted to make sure of something. And I have first we were bracing atrium, so the ventricle was staying the same. But then at this point, the ventricle on the QRS changed. It means that I believe there is something took over on the ventricle side. والله قصدي حضرتك ان احنا خلاص بدنا نكوندكت على الاكسسوري باث واي.
ايوه عليك نور، هذا القصدي. اوكي يعني you are going you are pacing the atria صح؟ you're going down the AV node down an accessory pathway. زين؟ normally normal accessory pathways you will see WW obviously because they are fast. In this case, it's an example of a slowly conducting accessory pathway that is only seen when you are decrementing the accessory path or the AV node so much, basically. Okay, going forward, it's a little bit small, and I apologize for this. بس ال AH في ال AH interval طبعا يعني roughly it's prolonging، يعني كان 16 هذا مو milliseconds، مجرد arbitrary numbers. It's AH clearly prolonging like you observed وائل. إنزين بس تشوف ال AV is يعني so slightly ال AV is slightly prolonging. Okay, بمعنى يعني if your AH is prolonging, you would expect the AV to be also prolonging at the same interval. Okay, in this case the AH is prolonging أكثر من ال AV prolongation. بمعنى إن ال H will V distance is coming shorter. Okay, plus there is widening of the QRS, then you know you're going more across the accessory pathway. So this patient had a Maheim type accessory pathway. This is a patient that we had, yani, this was 2 years ago, roughly, or I don't know, 1 year ago. Yeah, 1.5 years ago, صح? 3 months ago. Okay, so this is an example of ours, a Maheim. بمعنى it's a accessory path that is very slowly or slowly plus decrementally conducting. This is not your typical accessory pathway behavior. Okay, يعني this is one example. These are difficult patients, difficult to realize, and then يعني they are a little bit difficult to ablate as well. Okay, this is an example of Maheim accessory pathway that I promised to show you. Okay, questions? I know this is a little bit difficult, but the point here is you are decrementing the AH interval way more than the AV interval, and you have your HV interval shortening, and there is widening of the QRS. Hence, there is accessory pathway present in this case. Okay, مفهوم or not?
Yeah, clear, doctor.
Yeah. Okay. أنا يعني again normally the AH prolongs without QRS change if there is no accessory pathway. If AH prolongs with widening of the QRS and HV shortening, this is evidence of accessory pathway. This is definition of accessory pathway. And you know, Maheim accessory pathways are pathways that are that only manifest such features when you pace very fast. You know, because they are very slowly conducting. Okay, and they don't manifest until you very slowly conduct when you're going down the AV node very slowly. Okay, so you have to pace very fast to show them. Okay, yeah, they are always hidden because the AV node is fast, so it hides them. Okay, when you slow the AV node, for example, if you give adenosine, this patient, if you give adenosine and you A pace, you will see widening of the QRS. You will not see AV block. Okay, if the adenosine if that pathway is not sensitive to adenosine, okay, which sometimes it is. Okay, so this is end of part 2, and I thought to start basics, atrial pacing and ventricular pacing, and know what to look for and know how to diagnose a patient before moving the catheters. And this is just placing the catheter and just do pacing. Okay, makes sense, guys? Any questions? Was it clear, difficult, medium? And it's recorded, so you can listen to it again if it's not super. And if you want to, there's so much information, so I understand if you want to listen to it again. But and I hope I made it a little bit easy. Questions? Mariam, Ahmed, okay?
Yeah,
Yes,
okay.
it's clear
for
for
me.
me.
Okay. I think it's just medial, so there's a lot of information just to also like revise and keep.
Okay, and I'll post that on YouTube, and you should, this is 101 EP, and I suggest you guys to either read or listen to read obviously, but if you want to listen to this and know this information, because this is every case we will use such information. Okay. And if you guys, if you have more eyes for the same patient, the outcome would be better. We might miss things that you capture or you see, and you let us know, oh, I see this, I see that, I see this, and then you alert us. Okay. We cannot see each and everything. We miss things. If it's just one observer, we will miss things. That's why your education is very important, even for us, for the patient, and so forth. Your eyes are very essential for the case. The better your eyes is, the better the outcomes for our patients. Okay. Okay. And I don't know, Tamer did not make it, huh? خلاص, I will, inshallah, he can listen to it on YouTube. And I'm not sure there's an iPhone there. I don't know who is this. I don't know whether Salih or someone else. Hisham left us. Okay. Questions? خلاص, we will, questions before we end?